This was not needed. Yeah. So we are going to start this webinar on family planning. I must say that very, very consistently, ICOG has supported the thought of discussions on family planning coming up on a very regular basis. And I'm really grateful to Dr. Rishikesh Pai, Dr. Lakshmi Srikhande, and of course, the sitting vice chairperson, Dr. Parag Beniwale, Dr. Madhuri Patel, Dr. Ashok Kumar, for giving us this opportunity to bring this matter in front of, to the forefront, wherein we have key issues of family planning and contraception services, how to improvise, how to meet the unmet need, and what difference can we make to the existing practices in contraception. It's very imperative that we gear up, we do something more than what is already being done, because very, very recently, I think we did stand very correctly informed that India is equal to China now in numbers, and in density. Anyway, we are the densest country in the world, but we need to gear up and do something more about this. Now, today, we thought that we will have first and second session. The first one is on hormonal contraception related menstrual patterns, approach and management, because all of us who are on a regular basis prescribing hormones for contraception, we always face these difficulties from the client's side, that there is irregular bleeding or some changes in patterns, and we need to improve our skills to manage them, or else there will be discontinuation or loss of confidence in the method. And then there is also the stickiness which happens to the method, which gets told to from friends to friends, because I think if the negative experiences related to treatment is shared by women more often than positive experiences, and everybody kinds of gets alerted in that particular patient's circle that, okay, this method is causing these problems. That is what happened to IUCD. That has what been happening to some extent to LNG-IUS, and especially to copper IUCD. So let it not kind of affect our performance in this field. And to take us through this very vital subject is none other than a very expert speaker, somebody to whom we all look up to, Dr. Noser Sheria. Before I formally introduce him, let me just tell you that the second session is planned in a way that people from all sector can come in and give their opinion, and that is on tailoring contraception services for the youth. And if you see, my co-moderator is my predecessor and the former vice president of FOGSI, Dr. Basak Mukherjee, my predecessor as chairperson of Family Welfare Committee, also an expert in the matter. And the responders, the experts, are from every sector. They are from FIGO, Dr. Hema Divakar, Dr. Kalpana Apte from FPAI, Dr. Sampath from our own FOGSI, the sitting vice president, Dr. Sangeeta from IPAS and IDF, and Dr. Pragati Singh, a real value add-on from WHO. So we have a very expert panel to, to follow the talk, and I do hope that everybody will benefit. So I think it is only correct that I think this slide I'm going to skip. Now, to introduce the chairperson of ICOG in absentia, I think Dr. Lakshmi is in UK at present. She has sent her regards, and she has also kind of told Dr. Parag, handed over the session to Dr. Parag to preside over. So I will be shortly asking him to give his address, but it is my duty to inform everyone that Dr. Lakshmi Srikhande has proven to be one of the most dynamic ICOG chairpersons, and I'm especially grateful to her that she has encouraged this particular subject of family planning, family welfare and contraception. And I'm really grateful that we have been consistently able to conduct these sessions every month. Now, Madam has, apart from the current post, she has been the national corresponding editor for the Jogi journal, and also significant post in the Association of Medical Women India. It is known as AMWI, I think. And she has also founded the ISOPAP Vidarbha chapter, chairperson in IMS Education Committee in 21-23, and president Association of Medical Women Nagpur, and several awards to her credit. A very illustrious time as committee chairperson in FOGSI, where she won the best committee award as well, and several appreciations. So we do look forward to your participation in the next, and we hope that you will find some time to log in to today's session. Thank you, Dr. Lakshmi, for being there. And I think I must have Dr. Parag's CV somewhere, please. Nilima, how is it that? Hello, Nilima.
Shobha, it's okay. It's absolutely fine.
Because I saw it in the last one. Here I'm not finding it. I think it is.
No, that's okay.
So then I will stop sharing, Parag, and I will introduce you on the open gallery.
No. You don't have to just vice chairman of ICOG is good enough for the ICOG program.
No, you are that, and you are so much more. First of all, you are a very warm-hearted person, a dear friend to many FOGSians, and you have done hand-holding for many chairpersons in the past. You're still doing that. And I am especially grateful to you because there has been nothing but encouragement from your side. And sometimes, yes, constructive criticism also, which has really benefited me. And also you have given value faculty participation in many of my programs, because you have always said that family welfare is so close to your heart. Parag, I request you to address the gathering and open this forum and say a few words. Thank you so much for being here.
Thank you, Shobha, for those kind words. Good evening, all. I bring greetings from ICOG, the Indian College of OBGYN, which is the academic wing of FOGSI. And it's indeed a pleasure to welcome everybody for another episode of FOGSI ICOG Sankalp, which is a webinar on family planning. Dr. Lakshmi Shrikhande, the chairperson, is out of country and is unable to join. So I'm doing the job which she's normally supposed to do. Contraception is something which is really important to our country, especially now we are the most populous country in the world. There is still a lot of unmet need, and we as healthcare providers of women should take it very, very seriously and do our best to prevent unwanted pregnancies and help our women. I must appreciate the work being done by Dr. Shobha Gudi, former chairperson of Family Welfare Committee, and of course now our governing council member.
I'll have to keep the mask out.
Yeah, Ritu, can you please unmute?
Yeah, of course. Yeah, I can see you.
Yeah. No. I'm addressing the gathering.
I'm hearing.
Yeah. All right. So the subject that we've chosen today is really interesting one, because it is going to deal with two aspects. Whenever we talk about hormonal contraception, and Shobha, as you rightly mentioned, the side effects are the ones which are really publicized much more than the benefits, and that leads to poor use of contraceptive devices. And we could not have asked for a better speaker than Dr. Noza Shehryar. Welcome, Noza, to FOGSI ICOG. And I'm looking forward to the panel discussion, because the profile of the youth has changed, their needs have changed, and talking about contraception and tailoring the contraceptive services for the youth is extremely important. So I hope all the participants here would go home with good take-home messages, and that would translate into good practices, which will be of great help to our women. So Shobha, thank you very much for organizing this program, and let's begin the session.
Thank you so much, Parag. And as we go forward in the discussions, I'm really hoping for your inputs as well, because that will be of extreme value, and also your vision for family planning and family welfare and contraception when you take over as chairperson next year. That will be of interest to see, because I'm sure you will have a special place in your ear for this this much needed by ICOG. So I'll attempt to share my screen again and introduce the chairpersons for the first session. It is really my honor to introduce the chairpersons for Dr. Ritu Joshi and Dr. Sheila V. Mane. I think I take special pleasure in both of these. They were vice presidents together in 2014. And for me, both of them have inspired in different ways. Dr. Ritu Joshi, Senior Consultant at Fortis Escorts, Surya Hospital, Jaipur, Vice President 2014. She was a very well celebrated chairperson of Family Welfare Committee in 2009 to 2012. A really rich tenure she had. Of course, she.
Dr. Shobha, enough.
Yes.
Let's hear the speaker who's a bigger celebrity.
Yes, madam. Yes, ma'am. Yes, ma'am. So thank you so much, Ritu ma'am, for being there for me throughout my chairpersonship, even before. And it's your encouragement which made me stick to that committee and get it when the time was correct. I also take special privilege in introducing Dr. Sheila V. Mane. The significant work that she has done in PPH has been acknowledged by everyone in our country. Currently, she is DNB faculty at KCG, ICOG Governing Council member as well, and also the vice chair elect for ICOG. She also has other organizations to work like ISOPAP, and also she was the past president of Bangalore Menopause Society. Yes, Sheila has been again a mentor for many people like me. So I invite both of you, and I shall now share the CV of dear Nozer sir, and I request Dr. Ritu to introduce sir. Yeah.
When such celebrity doctors are not needed to be introduced, I think Nozer, everyone knows you very well. And I know his passion on family planning issues which are there, which could be in the form of contraception as well as MTP. So Nozer, let's get down to listening to your talk.
Thank you. Yeah. Thank you, Ritu, for that very effective introduction.
Love you for it.
And thank you, Shobha. You have always included and challenged me in a topic that after I said yes, I said, my God, how am I going to get this topic done? Because it's
not I couldn't think of anybody else who could do justice to this subject. Yeah.
So I'm going to share my screen now, and I hope you can see the screen. Ritu, can you see the quote?
Yes, sir.
Yes, sir.
Thank you. So Jeff Bezos says, everything you are comes from your choices. And we live in a very good time. But I remember a time when many of these different contraceptives were not available in India. We claimed to have a basket of choice, but we really didn't. And now if you see the hormonal contraceptives on the left, with the exception of the patch, which I'm really waiting for, and the ring, which we had, but which disappeared, we pretty much have everything in our country. So today I will speak to you about hormonal contraception related menstrual patterns. The idea was first to talk about menstrual disturbance. And I said, why should we just talk about disturbance? Let's talk about patterns, and let's talk about our approach, our management, and the concept of menstrual manipulation, which is a very, very important use of hormonal contraception. So going back to the beginning, our 21/7 COC regimen comes from Gregory Pincus proposing a regimen of 21 days with a 7-day drug-free interval. And his partner at that time, John Rock, who was a very devout Catholic, thought that by having a 28-day cycle, it would be a morally permissible variant of the rhythm method, and it would be acceptable to women clinicians and the Catholic Church. We know that the women and the clinicians accepted it, but the Catholic Church did not. But the original intention was to make women feel it was natural because they had a 28-day cycle. Well, we know now that you don't need to have a 28-day cycle, because when you are using hormonal contraception, you can do what you want with the menstrual cycle. And this was first proposed by Loudon in 1977, when he suggested using the active pills for 84 days and then taking a break for 7 days. This reduced the frequency of menstruation to every 3 months. And today, at least I very liberally use extended COCs. Usually, I prefer going up to 42 days because I find when we go beyond 42 days, the chances of breakthrough are very high. So many studies have investigated the extended and continuous use of oral and other forms of contraception. Today, we also have a concept of menstrual manipulation and suppression. By using hormones to adjust the menstrual cycle and allowing women to have periods as often as they want and to avoid bleeding at inconvenient times. Now, we've been experts at that because, you know, ours is a very religious country and menstruation is frowned upon, which I think is really sad because it shouldn't be. But around the time of Ganpati, festivals, ceremonies, the Hajj in Muslims, women don't want to menstruate. And we've often used menstrual manipulation there. We have benefits of menstrual suppression. And there are fewer menstrual-related syndromes and conditions that are exacerbated by hormonal changes around the time of menses can be taken care of. Our major disadvantage is that when you go for extended menstrual manipulation, you will have a higher rate of breakthrough bleeding. Now, this quotation really caught my eye. They said there are only patterns, pattern on top of patterns, patterns that affect other patterns, patterns hidden by patterns, patterns within patterns. What we call chaos is just a pattern we haven't recognized. What we call random is just a pattern we can't decipher. So let's start with combined oral hormonal contraception. Traditionally 28 days, 21/7, or now 24/4, invented to mimic a natural cycle, along with a very regular cycle, almost clockwork. And I tell women that when you're on the pill, the cycle belongs to the pill, not to your hypothalamus, pituitary, ovarian axis. There's often a reduced flow, there is reduced pain, reduced PMS, and we know about all the cosmetic benefits. When you have a breakthrough bleed with the pill, you often have it with lower doses of estrogen, or you have it when there is poor compliance. Now, the pill is only as good as the woman is. And in this case, the lower the pill, the less forgiving it is. A 30 microgram pill is very forgiving. 50 used to be even more forgiving. Thankfully, we don't use 50 anymore at all. 20 microgram is less forgiving. So if you are careless with the pill, I tell a woman that you will have your body waiting to break through. Some women will have amenorrhea on the pill, and all they need is reassurance. And this often happens as you lower the dose, because you have a very low dose, the endometrium is suppressed, and you won't have breakthrough. And occasionally there may be intermenstrual bleeding or spotting. Traditionally, we were told about post-pill amenorrhea as students and as young practitioners. I remember we did have it. But ever since we've gone to the contemporary pills of 20 and 30 micrograms, this is no longer a problem. Coming to combine non-oral hormonal contraception, we had a good time using the contraceptive vaginal ring. Effective for 3 weeks. It had ethinyl estradiol and norgestromin. In fact, I had a patient of mine who was so smart, she could never remember to take the pill. So she was on the ring. She would leave the ring in after 3 weeks. She wouldn't take it off. She would get at least 1 week more. And then when she had the first sign of the period, she would take a break. And she would joke with me that she would get a free ring every 3 cycles because she would get 1 week more in every cycle. And I still do that with a lot of my contraceptives. I have patients on the patch, wonderful, Ortho-Evra. I ask them to bring it from overseas. And particularly if you have patients with liver issues, with raised enzymes, if you have patients with gallbladder disease, the patch is a great option. We live in a very international world. Many of our patients have links and travel. And if you can use this, it's fantastic. One patch for a week, 3 weeks on, 1 week off, and you can always leave it for more than 3 weeks. Cycle is extremely regular, better than the pill because compliance is better. You're less likely to have anything forgotten because as long as you have it there, you are protected. Occasionally, there is amenorrhea, very rarely intermenstrual bleeding, and they've found that with these methods, your use effectiveness is almost equal to your ideal efficacy of 99+%. Because busy women, mothers with small children who have a problem remembering that pill every day in spite of reminders on phone and in spite of giving them all the tricks possible, don't have a problem with this. Coming to progestogen-only hormonal contraception, and we have desogestrel and now we have drospirenol. Thankfully, desogestrel is back. Basic issue is irregular cycles with unscheduled bleeding or spotting. But since a majority of patients use this for contraception, which is post-delivery during lactation, we have a lot of them having amenorrhea, and not just amenorrhea, extended amenorrhea, longer than lactational amenorrhea would have been. You could also have frequent bleeding episodes, and I'm going to come to this a little later. And coming to the bleeding pattern with a long-acting injectable contraception, and we have the DMP available to us. Unfortunately, subcut came and subcut isn't available. The best amenorrhea rates come with injectables, 50 to 70%. In fact, if I need amenorrhea, and if I'm using for this for the non-contraceptive use of frozen pelvis, severe endometriosis, I will start off giving it once every month or 2 months, make her amenorrheic very quickly, and then move on to my 3-monthly DMPA, where you give 150 milligrams deep intramuscularly every 3 months, works beautifully. You could also have irregular cycles of bleeding. You could have frequent bleeding episodes. But interestingly, and this study in contraception tells us that because the woman was counseled about the menstrual disruption, it was better tolerated than other methods because she was told about the amenorrhea and she was told about the irregular cycles. Coming to the levonorgestrel intrauterine system, many women will have regular cycles. Most will be hypermenorrhea. They'll say they just spot, but the spotting may go on for a longer time. About 20% become amenorrheic at 6 months and 50% at 5 years. And I often use this device, I must confess, for 7 years, which they are telling us now, but I've been doing this for the last 20 years. Works great. And sometimes I even go from 7 to 8 years. 30% might have irregular unscheduled bleeding, and a very few might have heavy bleeding, which needs to be dealt with. And finally, the hormonal contraceptive implant among the contraceptives. We are lucky to have the etonogestrel 68 milligram implant. It releases a fixed dose. This dose gradually falls over 3 years. I am tempted to use it for more than 3. At the moment, I'm changing it at 3. Regular cycles in many, hypomenorrhea in many, amenorrhea in 25%, but a small group of people may have extended periods of spotting and might even have heavy bleeding. But it is said that the bleeding, I will come to this in the next part of this talk, than if they were not using the method.
Hello. 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 Hello, Nilima. Yeah. Yes, sir. Can you unmute?
Shobha, can you see my screen?
Yeah, no, not yet, sir. You will have to share again, sir.
Oh God.
There was
Okay.
some disruption in the connectivity, I think.
I'll just have to.
Please share again.
Is the screen seen?
Yeah.
Okay. So when CIPLA pushed emergency contraception in a big way, there was a government meeting to express concern about this misuse of emergency contraception. I requested to be the first speaker. I was holding FOGSI office bearer positions back then. And I said, I want to speak on the misuse of emergency contraception. I was the first speaker, and my opening slide was, emergency contraception cannot be misused. And interestingly, when you look at these disturbances, just before that meeting, I had two patients who'd come to me. A 26-year-old unmarried had come with persistent irregular bleeding over 6 weeks. She said she'd used 4 emergency contraceptive tablets in 1 month. A 28-year-old persistent bleeding 1 month, 5 emergency contraceptives since 1 month. But the commonality was they were young, they had no male support, no male participation, not using standard contraception, didn't have condoms. So I said, it's fine if they've used this. And the best thing is they will come to a gynecologist. The only thing a gynecologist has to do now is, if you get a woman with abnormal uterine bleeding, one question to add is, have you taken emergency contraception in the last few weeks? It's become an important question. And the best thing is that they will be willing to accept other methods for the future. Now, Steve Jobs has said, if you define the problem correctly, you almost have the solution. We started by defining the problem, but to assess these disturbances, the WHO proposed definitions over a 90-day reference period. B/S is bleeding spotting. Amenorrhea is no bleeding. Infrequent is 1 or 2 episodes in 90 days. Frequent is 6 or more episodes in 90 days. Prolonged is an episode lasting for more than 14 days. You ask the patient to keep a bleeding diary, and this helps improve a woman's acceptance of bleeding patterns if you explain this to her. The pill. The US FDA approved this way back, and they approved what is called as the seasonal, which was 84 days of COCs with a 7-day break. And this is the treatment for PMS, PMDD, gives you an atrophic endometrium, works great. My own issue is that it probably gives you, this probably gives you breakthrough bleeding after the first 42 days. They've also proposed continuous regimes where you have 365 days of pills continuously. Again, your concern is more breakthrough bleeding. So how do you manage breakthrough bleeding? Firstly, check compliance with the pill, patch, or ring use. Are they using them correctly? Are they changing them when they have to? Are they taking them on time? Determining the dose of ethinyl estradiol or the type of progestogen is important. It is found that herbal supplements, which a lot of women use, and smoking interfere with estrogen metabolism. And this is a downside to suppressing withdrawal bleeding. And while I do use extended COCs, endometriosis, PMS, so many things, you may achieve what you want to achieve with a short periodic break. What do I do for this? Tranexamic acid, 500 milligrams to 1 gram 3 times a day during the significant bleeding. Teach the woman to take a double up pill from the spare pack on the days when she has spotted, to kind of suppress the endometrium and take charge again. Increase the estrogen dose in the birth control pill from 20 to 30 micrograms. This is the reason why I start with 30. 30 months and then drop. Why can't I have a group? It shut the woman's confidence in the pill. I'd rather give her 3 months of 30, build up confidence, shift to 20. If those 15% breakthrough, they can go back to the 30, the remaining stay on 20. And finally, change to a second or third generation COC because levonorgestrel is the most potent when it comes to winding those spiral arterioles. Desogestrel is excellent. And if I have this kind of bleeding, I am going to step up to that particular preparation. These are the patterns for the progestogen-only pills. Just to tell you, amenorrhea would be 10 to 20%, but there'll be quite a few patients. It decreases over time who will have those, frequent bleeding episodes during the reference period. And this is the bleeding pattern for the implant, where in 90 days, the mean bleeding days, spotting days are about 17, and the mean episodes are about 2.5 to 3 days. How do you address amenorrhea? The first question is, do you need to address amenorrhea? It requires counseling, reassurance, hand-holding, DMPA, highest rate of amenorrhea, LNG-IUS most convenient. I start off by telling my patient that it's abnormal to menstruate regularly, and I've caught their attention. They think doc's crazy. I mean, how can it be normal to not menstruate? Malcolm Gladwell wrote an article in the New York. He wrote about a scientist lived with this tribe, of a tribe, in a track women going to the menstrual hut, and these women menstruated barely 100 times in their lifetime. Contemporary women menstruate 400 times in their lifetime. So I tell a woman, fibroids, endometriosis, adenomyosis, chocolate cysts are all the result of modern menstrual patterns. And if we use more hormonal contraception, we would actually be better off. But some women may still want to menstruate, particularly after the injectable is over. 3 months later, she's still not menstruated. What do you do? Ultrasound to check endometrial thickness, rule out pathology, and for God's sake, rule out pregnancy. She stopped using her injectable. 2 months have passed. She still hasn't gotten a period. Please make sure she's not conceived before you move ahead. If the endometrial thickness is adequate, I will use progesterone withdrawal, MPA, or dydrogesterone, or micronized progesterone for 5 to 10 days. And if the endometrium is adequate and progesterone levels have fallen, she will menstruate. If the endometrium is inadequate and the woman is getting all worked up, give her an estrogen progesterone cycle. We call it a challenge test, but here it's therapeutic. I used to love using ethinyl estradiol 0.05 milligrams, that's 50 micrograms, not available. So now we use estradiol valerate. And then you give a progesterone withdrawal and it usually works. Or you can use a combined oral contraceptive pill, though I prefer to first give estrogen, build up the endometrium, and then give progesterone. What about the heavy bleeding? I mean, she has been on something, she's on an implant, she's got an LNG-IUS. Usually this is with an implant or with injectables. Start off with tranexamic acid. The best way of controlling bleeding is by giving estrogen. People think progesterone for everything. She's already got a lot of progesterone in her system. Her endometrium has got those changes. You want to support the endometrium, so start off with estrogen, give it for 25 days. The bleeding will stop, give her a withdrawal, get a shedding, and move on. Then you could also do the combined OC, ethinyl estradiol, 50 micrograms or 30 or 50 with desogestrel or levonorgestrel. And finally, in some cases where you feel the progesterone secretion is erratic, you may consider progesterone supplementation and suppression. You can start off with TDS for 5 to 7 days, BD for 5 to 7 days, OD for 5 to 7 days. 5 minutes. Now, now comes the irregular prolonged bleeding, the spotting. This is the challenging one. It just goes on and on and on and drives that woman crazy. It can happen with injectables. It can happen with the levonorgestrel IUS. It can happen with the implant. Start with tranexamic acid. Give her the estrogen use and the withdrawal. It will usually control the bleeding. Consider the pill, but here you've got 2 or 3 other options. I don't have experience, but every time I've been on a group which has been talking about this problem with the implant, there are Indian gynecologists who've got great experience with ormeloxifene cencroman. Twice weekly, 12 weeks, 1 weekly, thereafter they swear by it. You could also use tamoxifen 10 milligrams twice a day for 7 days, or you could use ulipristal, it's back, the anti-progestogen, 15 milligrams, that's 3 tablets of 5 milligrams once daily for 7 days. So Michael Dell has said it's through curiosity and looking at opportunities in the new that we've always mapped up. Interestingly, all my quotes, centered, structured interview, and you've told her about all these things. Effective contraceptive use is much better. Just telling the woman that you're going to have this pattern, and FOGSI did this, Ritu was the chair, Basab, we've been using this. And this chart that was made for a select study actually told women about the specific characteristics and the irregular menstrual bleeding with which hormonal contraceptive. And that made women make better choices and accept methods because they were better prepared. COCs went up, ring went up dramatically. It was there at that time. Progestogen only went up, injectables went up, LNG, IUS went up. And it was clearly shown that a routine counseling group versus a structured counseling group was way, way, way different, where after many months, women had dropped off because they were disturbed by the menstrual disturbances, and with the structural counseling, they went on because they were prepared. So I would like to end this lecture by quoting a woman, Anita Baker, because finally, it's not about us. We tend to push things because we get so carried away. I know of people who did dozens and dozens of the ring because they were passionate about the ring. Going overboard with the implant, not put it in the hands of someone who doesn't know me well. I know me well. She wants to menstruate, give her an OC pill, let her cycle every month, or give her a copper IUD. She's okay with amenorrhea and she lights up and says, wow, doc, no menstruation. Think of a lark which will stop her periods, and explain to her what the consequences are. And if you do that, you will get the best results of what the woman accepts. Thank you, Shobha.
Thank you, sir. Sir, you will have to, yes, the spotlight has to be removed. Yeah, thank you so much. Sir, that was amazing fine tuning and really good take home messages. I think you covered every clinical scenario. I think I'll leave it to the chairpersons to discuss. Yes.
Has Dr. Sheila joined, Dr. Shobha?
Not able to see her yet. Yeah, not able to. You please carry forward, madam. Yeah.
So Noza, it was lovely listening to you with all the facts being put forward, and I know how well you make your talk, and the message might be the same, but the talk is always very interesting. And I remember how we had done that SELECT study, which was so well done by all of us. Parag was a part of it, if you remember well. And I think it has really been an excellent talk. And let me also share over here from this podium that he's got an excellent book, which is one of the best sellers today, which is Finding Your Balance of 360 Degrees, something like that, on perimenopausal, for perimenopausal women.
Yes.
That's a big hit, big hit. Correct. So Noza, thanks a ton for that.
I think sir has always been the speaker who gives very, very strong take-home messages. So I'm really grateful that he took up this complex subject, because this required a lot of preparation, in the sense one has to look at every different clinical scenario, and he has left nothing to doubt. I feel it has been a real eye-opener, because it has told the audience that how much finer skill we require to manage the consequences, and in order to improve the continuation rates, we need to understand hormones so much better. And the different strengths of COCs, the different progestogens, the use of ormiloxifin, the use of the continuous use, and these talks like these will give courage to prescribe more and more hormones for longer periods of time, because that is something that practitioners hesitate a lot. And the best thing was the individualization, I think, Ritu ma'am, the way a patient is approached and what she needs and what she feels. And that is the hallmark of this talk, that it has helped us to understand that contraception is tailor-made, and even the management of problems is tailor-made. And that was very, very interesting. Thank you so much, sir. Thank you so much. I always find it very, amazing that Sonavala sir is finding time to join us. Sir, you have anything to share on this particular matter? It will be great to take your views before we open the panel. Yeah.
No, this hormonal contraception is a little tricky. As Nozer has already expressed, each individual will have a different pattern and each doctor has their own fancy. So, at least in my practice, I used to give the choice to the patient. Those who were willing to use hormonal contraception and were very tuned to know that a breakthrough bleeding or a little, say, irregular period, one has to accept. In the long run, I was more favorable to the intrauterine contraceptive with proper selection. A patient with cervicitis and infection, you cannot put IUCD. So these are certain drawbacks which are there. But in the long run, when one needs a long-term protection, and if a permanent method like tubal ligation and husband is not willing for a vasectomy, then intrauterine device, especially the hormonal one, would be a good method for a country like India, because once it is inserted, the original thinking every 3 years one had to change is not necessary at all. One can go up to 6, 7, 8 years, because after the hormone is exhausted or removed, it works like a mechanical IUCD. And that's why, in my opinion, for the country, for as a contraceptive, IUCD may be a better, but it will all depend upon how enthusiastic the clinician is and how well motivated and counsel the patient is. And long-term side effects, we don't know yet. When hormones are given for maybe 20 years or something like that, the long-term side effects are also to be kept in mind. So far, at least, it has not shown any harmful side effects as such. Thank you, Dr. Goody. And see you tomorrow, Nozer.
Yes, sir. Thank you. Yeah. So, yeah, I am not able to see anyone else has any questions to ask, sir, because I have made it a gallery. So anybody can ask any questions. Yeah, I had one. Yeah, somebody has asked, Dr. Padmavati has asked, the DMPA causes amenorrhea more than a year after the last injection. And it is very challenging to explain that to the woman, because she'll be waiting for fertility perhaps. Maybe that is her concern. Yes, Dr. Padmavati, sir will take your question.
So this would be an outlier. But you're right, it could be an extended amenorrhea, and now that she's finished, it depends upon what she wants. If she wants fertility, you don't have to wait for a year. As I've told you, we have ways of dealing with the amenorrhea. It all depends upon the endometrial suppression. If the endometrium is very suppressed, then you probably have to go to estrogen, let her start menstruating and feel good about herself. And you could continue her with cyclic estrogen with a progesterone withdrawal for some time. You could put onto a birth control for some time, and she would menstruate. If she wants fertility, maybe give her 1 or 2 cycles estrogen, progesterone, and then you could get on with ovulation induction, because it's basically worked not by its effect on the uterus and the endometrium, but by ovarian suppression. And we know that when there is ovarian suppression, that's exactly what infertility specialists do. They go ahead, suppress the ovary, then hit them with ovulation induction, and you could definitely do that. So nothing you find you are an outlier. We're going to make sure you get your periods, and if you want fertility, we will go for fertility.
Correct. I think one problem which perplexes them is that's what the same thing she has asked. How long can we wait for her to come on her own to have?
So it completely depends upon her.
Correct.
If she's been using LARC
Hmm.
because she says, I don't want any more pregnancies, she doesn't need to menstruate. And I've already convinced her that menstruation itself is not a great thing to have.
Hmm.
Not menstruating is probably more in your benefit. And the moment I ask my patient, how many brothers and sisters did your grandparents have? And trust me, a majority will say 7, 8, 9, 10. And I say, you know what? Your grandmother never menstruated, and she was probably better off health-wise than you. The amount of endometriosis, fibroids, and the other stuff we are seeing today might actually, if we are able to convince women about the role of hormonal contraception. I feel so sad. We know that the birth control OC pills can actually reduce ovarian cysts, can reduce endometriosis, can reduce ovarian cancer. We know that. We haven't been able to convey that to women. We know that using progesterone-only methods reduces the incidence of endometrial CA. And we are seeing an uptake of these things in our practice. Why haven't we gone for preventive medicine using contraception for other than contraception?
Exactly. Very, very valid point.
It doesn't matter. She wants to menstruate, give her what she wants. If she comes to you, and I've had a few of my implants coming back saying, menstrual irregularity, I want it out. Now she's taken the trouble of inserting it, but if she wants it out, it comes out. We have sometimes made patients keep things because we get so attached to the thing. You know, you put in an IUD and the woman can't get it out when she wants to get it out. And then she'll go to someone else and get it out. But that's sad, because at the end of the day, it's her decision, which may be a right decision or a wrong decision, as to whether she uses something or not. You want to menstruate, I'll make you menstruate, but you don't need to menstruate, so you can wait. Do you want fertility? We'll give you 2 or 3 menstrual cycles, and then we'll get on with fertility treatment.
Yeah, sir, Doctor. Yeah, I think that is individualization and patient's choice that you have conveyed. That's Dr. Rinku Rawat Bhaskar. Sir, please comment on weight gain associated with DMPA. And Dr. Padmavati.
Very variable. So I must confess here, I have patients. I have a patient of mine who's been on DMPA now for almost 18 to 20 years. I have patients of mine who've been on the pill for 17, 18 years.
Correct.
Dr. Sunawala very rightly said that there is no evidence to show any disadvantage, but you have to keep reassuring, monitoring from time to time, seeing them and keeping them going. If you've counseled this woman to be good with her diet and with her exercise schedule, if you've monitored her carefully, trust me, yes, there is evidence of weight gain, but it's not as much as people think there will be. I sometimes joke with my patients that, women are very good. They can manage weight gain without any contraception. So don't blame the contraception for it. But it is an issue. We also worry about bone density. This patient of mine has been having bone densities done since years. And because she has been counseled, we make sure calcium, vitamin D levels are good. Because she does a strength training and weight bearing exercise, her bones have been just fine. And I'm talking about a number of patients I do this with. But you have a responsibility of informing the woman that these could be issues, and then allowing her to make the decision of continuing, not continuing, accepting, not accepting. So if a woman is very, very concerned about body image and weight, you're probably better off not using the injectables. Use something else. The pill, the first thing you get told is, my God, I'll put on weight. But don't you know that drospirenone by nature of its activity will actually cause some amount of reduction in fluid and actually lead to a minimal weight loss? And when I tell them that, they will grab it. So I tell them drospirenone OCs are weight neutral. If I'm using an OC which is 35 micrograms, and you know which one I'm talking about, I'm convinced that tends to cause weight gain. And I will never use that cyproterone OC. It's great, it's fabulous. I will use it for getting my cosmetic benefits for 3 to 6 months and then shift around to something with drospirenone.
That's an excellent message, sir.
And you start off with 30 and you drop her down to 20.
Yes.
And keep her on the lowest effective dose for her and give her the other lifestyle advice. For me, a cornerstone of practice has now become diets. 2 dietitians are a part of my practice. I can't practice without them anymore. And it's time for us as doctors to start accepting writing a prescription is not enough. We've got to write something for a lifestyle. If we are not qualified doing it, let us get it from someone else.
Yes. That was a wonderful take home for girls with PCOS. The number is increased so much today in our practice. They come with needs for cosmesis, for regular periods, for other benefits, and we know how to fine tune the prescriptions if we read between the lines of what Sherrier sir has presented today. And now he very rightly said that prescriptions have to be holistic, have to be well supported by other disciplines, and also the concept of using cyproterone only to get the FG scores of hirsutism under control, and then switch on to drospirenone, the higher dose, and then the lower dose of ethnyl-estradiol. That is such a wonderful message, sir. And I think that is a way forward for treating such girls. So thank you, sir. I think I will just begin on the panel discussion now, since we would like to discuss this subject for many more minutes, but it is kind of constrained by the time we have. But I profusely thank you for giving your time out of your consultation, your patient time to us and enlightening us on this complex subject. And we can see the clap of hands by Dr. Hema Divakar, and many thanks coming your way. Thank you, Nozer sir, and probably if you're logged in at some time, if you could just throw in 1 or 2 statements on contraceptive services for the youth, I will be so grateful. Thank you, Nozer sir, with all my heart.
Thank you, Shobha.
Yes.
Thank you.
So it is my pleasant duty now to bring on the panel discussion. And Dr. Parag has promised me that he will put in an appearance in a short while. And I can see that my esteemed panelists are here. So let me, without wasting time, just share my screen to bring in a few more CVs onto the platform, and just begin on a very intense and crisp discussion on how we can improvise on contraceptive services for the youth. And to moderate with me and to lead the discussion is Dr. Basant Mukherjee, somebody who has become very, very well known to every FOGSian, the immediate past vice president of FOGSI.
Skip the CVs for us. Yeah.
And also
skip our CVs. Let's focus on the panelists.
Okay.
Yeah, I think both of you and me, we are okay.
Yeah.
Dr. Hema.
So it is my privilege and honor that Dr. Hema Divakar has joined the discussion today. Medical Director of Divakar's Hospital, Chair of Well Women Healthcare FIGO, Dean KCOG Karnataka Chapter, and President of Karnataka AHPI, the Association of Healthcare Providers of India, ex-Vice Chair for FIGO PNCD Committee, and past President of FOGSI 2013. This last one is where I started working very closely with Hema, and I have known her to be a leader par excellence. And thank you for being here, and advocate for delivering quality healthcare for Manyata. Everybody knows that she is the Manyata star, and she has helped so many facilities to acquire standards of care.
Thank you, Shobha.
The award list is very short here, so I don't want to kind of read it out also, because everyone knows that you are so richly decorated. Hema, thanks for being here. Dr. Kalpana Apte, very dear friend. And actually, I had corrected the CV and I had put it as Director General FPAI. I'm sorry, this is the previous slide which has come up here, but she is the Director General FPAI India, very, very high position in a very esteemed NGO organization, a member of Scientific Advisory Board of Pharmaceuticals and member of Reproductive Health and Technical Advisory Group, MOHFW, member ED Advisory Committee for Implementation of IPPF Business Plan, etc., IPPF UK, and member of Common Health Think Tank for Safe Abortion. Welcome, Kalpana. I hope you have joined. I have not been able to check. And then we have dear Sampath. Yeah, thank you, Barsar. We have dear Sampath, the sitting vice president and a real dynamite. And I don't know how many words.
Shobha, you go with the next speaker. We'll proceed. We'll proceed.
Sampath, thank you for being here because you have so much on your plate and you kind of think of so many things to do that I was surprised when you agreed to be here. Thank you, Sampath, for being here. And then I have Dr. Sangeeta Batra, the Chief Technical Officer, Health Systems IPAS IDF. And she has had a very rich experience in public health, provides technical support to, she has worked in close collaboration with the GOI and has led the development of training programs, active member of expert group for training on manual on implants. And that is something, the passion that I share with you, Dr. Batra, and National Master Trainer now for implant training, supports the implementation of adolescent health interventions. And that is why you are here in this forum, and faculty for national international events on SRH, especially CAC and contraception. So that is the reason. And then I have Dr. Pragati Singh. And don't let her youthful appearance fool you, because she is quite an iron lady. When I read her CV, a very rich work experience, a medical professional with specialization in public health, also possesses a certification on climate change and health from Harvard and climate solutions from University of Edinburgh. So, you know, I think she is much, much well-read than me. She's a national professorial officer in WHO now and supports the MOHFW activities for strengthening SRH. She has also led FP initiatives under USAID, and that is when I first met her, when I was chairperson as Senior Reproductive Health Advisor. So your work has been very dense, I think, but we shall see you as somebody who is representing WHO today. And with that, I'll stop sharing. And this is an open platform discussion, and there will not be any slides. So I invite Dr. Bassett to take on the conversation, start the discussion.
Thanks, Shobha, for so nicely and kindly introducing our esteemed experts. I don't think you can call them panelists. They're just sitting in a panel, but they are the one who will be doing the talking, and we'll be doing the hearing, and we'll be doing the learning. So tailoring contraceptive services for the youth, that's what we're going to discuss today. And so contraceptive services for the youth is always a challenge. In fact, contraceptive services for any age is a challenge, and youth is an extraordinary challenge, and that adds to a lot of things. So here we have a lot of people from the public health and leading clinicians who will give various perspectives of the problem as it stands now, what in their clinical space and in their area of work they help, they contribute to work towards it, or how they look at facing this challenge and how do they cope up with it. And that will be the first round of the discussion we'll have. And in the second round, we'll have the way forward and what do you think would be something which would make a more of a difference. Obviously, we know there are a lot of knowledge gaps. There are a lot of areas where improvement can take place. But what can be done at an individual level, at an organization level, is something which we will be keeping for the second part. So I have to start with Dr. Hema. Dr. Hema, you're straight there on the screen. You lead NCD committee in FIGO, and that's a little different here. But again, now we're focusing on tailoring contraceptive services for the youth. We know the epidemiology, we know the unmet need out there, how staring it is at our face. But if you would like to say from your point of view as a clinician, how you see this subject, how you face it, do you think we are giving it the importance that it needs? And how exactly you think are the ways we can how do you tackle the issues which you face in your practice? Thank you.
Thank you, Basab. Thank you, Shobha. The present position I hold in FIGO is the chair of the Well Women Healthcare Committee. I especially mentioned that, Basab, because the concept is the care throughout the life course. And it starts with the adolescent, right, until well after menopause. So when we want within our committee to make some recommendations at a global level, we have put contraception cutting right across all age groups, because, right from the first phase to the second to the last, because there are issues with the subject of contraception everywhere. And today we are tackling in the first age group, that is in the teenagers, being very well aware of the fact that this is in a very different way, a very forward-looking but vulnerable group. And most of the clinicians here would agree that in the last decade or so, the escalating prevalence of sexual activity amidst the teenagers, which makes the discussion about contraception a necessity. And even when we go to the school programs, the menstrual health and hygiene, a lot of things around that is built towards life skills and contraceptive practices. But most of the challenge for us remains that this is the age group which will not directly approach us, because it will go on the peer group, the social media, the teachers, the parents, and the doctors are a no-no. That is what the reality is. So just 5% coming to us, okay, at every touch point we are telling them something, but that is a minuscule percentage. So we need our presence out there. It's a reach out that we have to be focusing on. And till very recently, all my junior assistant will very coolly, boldly, clearly ask any young girl coming, are you sexually active? But for me, as a senior practitioner, it took a while, to ask such a question, that I should honestly confess, because what if she's not, and how she will respond, etc. But now it's kind of become a routine, because this is one of the part of the standard care questions that we ask, because only then she can open up. The last thing I want to say is the emergency contraceptive pill. I-pill is a preventive rescue factor for everybody, because we can never say when she will need it. Unfortunately, this preparedness is not there with the provider, I must say, because it only gained its, visibility when it came on the television advertisements. We could have at every touch point told about this to any teenager, that just in case, this is what it is, because they're aware of it. But one word from us makes them confident that in such a situation, yes, I can take it. Not that, that's the only way. The second point, and the last point I want to make, is insertion of a IUCD in a nulliparous. That is a very strict mind block in many clinicians. Many will not still agree that, that could be a way forward. So we have to sensitize and get these things round, and being non-judgmental, much theoretically as it's said, it is not happening in the reality of practice. So these are some of the things that we have still a long way to go. Cultural contexts are different, socioeconomic contexts are different. Girls coming from faraway villages to the metro cities want to experiment and explore on a lot of things. That is the ground reality. And how we can work our innovative ways around to reach them, to sensitize them, to make them behave responsibly, and to empower them with the knowledge and the use of contraception. That is what my take would be on this, the topic 360 degrees. Thank you.
Thank you, Dr. Hema. That's lovely. That's lovely hearing you. I think you've pointed out and enlisted almost most of the things which many of us as clinicians do face, and wish we lived in an ideal world where a lot of things would have been a little born differently. We move on to Dr. Kalpana after. Dr. Kalpana, we are so happy that you're here. It's such a pleasure to see you. You're the sunshine which we see in public health whenever we go anywhere. So thank you for being here. So this is about, so we're discussing tailoring contraceptive services for the youth. You heard Dr. Hema speaking from a perspective of a clinician, how exactly most of our clinicians face different issues in this segment and how we deal with it and how we wish people would be more responsible and how we wish we could reach out to many more people than we what actually do in a limited space in our clinics. So what we want to hear from you in FPAI perspective, which you were leading so long, and the public health organizations which you see and which you monitor, how easy or difficult it is for adolescents to come up to ask for contraception or to be approached for contraception, or do you believe in taking the discussion to their doorstep? How easy and difficult it is, and what are the challenges at the grassroots level at your public health? The people who are under the banner of FPAI, they work in different villages and towns. We know some of them. How exactly does it work there? Thank you. Thank you for.
Thank you, Dr. Basab. Thank you for having me, Dr. Shobha. It's a great group, and actual sunshine is right here in this virtual room. It warms my heart really to see that this discussion is taking place on this important issue. Dr. Basab, it's an important questions, and I would like to make 2 points, or rather 2.5 or around that. Number one, let's understand that we have the biggest cohort of young people ever in the history and future of our country. We never will have these many young people at one point of time. And therefore, it's a young country, and we have certain obligations to ensure that India is a country with public health system and responsibility to its citizens. So the public health programs need to be responsive to this huge cohort who is on an average going to be sexually active. Now, Dr. Hema has said it very clearly that even asking, and most of us come from a cultural background. And this is the one point that I would like to now make, that we need to remember when we talk about programming, of course, it's a Western concept and a Western world view. When we talk about total comprehensive sexuality education for young people, and Dr. Hema also spoke about knowledge gaps. You also alluded to that. Of course, young people do not have adequate knowledge, and it's important that they do have certain basic information about their own bodies and how they grow up and how things happen, how conception can happen, what protection to be used. They don't have. But let me tell you one thing. Every young person, each and every young person that I have interacted with and indirectly tried to understand their priority for understanding whether they are from slums, whether they are from a good household, good meaning, middle income, higher income, whether they are from rural areas, whether they are in schools and colleges, whether they are out of schools and colleges, they definitely, almost all young people want to know about what is sexuality, what is growing up, and how they can use it. I'm not saying everyone has an intention to be sexually active. No, I'm not saying that. I'm absolutely not saying that, because no, not all. Majority may not, even unless peer pressure comes in. And it's not also fashionable in many contexts that to be sexually active. And that also is a cultural context. So I'm absolutely not saying that people want to be sexually active, they have desire and whatever. No, we are not Western world. But the quest for knowledge is there. They need to know, they want to know. And therefore you will be, if you look at the data around porn sites, you will see, and we have very high reach of mobiles and internet. So that is a huge area where we need to work. So that's the first thing. And interestingly, I find it very interesting that we are all doctors, public health people, experts who are trying to deliberate and talk about how and why, how can we help young people. But if you look at the terminologies which are used globally, doctors, teachers, parents, principals, meaning all the significant senior people around a young person are known as gatekeepers. Gatekeepers to knowledge, gatekeepers to services, And I think that's a travesty, because there is a group of teachers, there is a group of principals, parents themselves who would really like to see that their young people are very adequately ready to face whatever come their way. So these are important issues when we think about access to contraception. Can only happen when the young person realizes that, yes, this is something that I need to think about. We also need to know that young people are not like married people, in the sense unmarried adolescents or young people who are not married. They're in casual relationships. Their contraceptive needs are not as similar to young and married young people. So these are immediately, there are two different pathways. Their casual sex is going to happen. It's not going to be predictive. And so therefore, of course, I completely agree on the emergency contraceptive pill, because everybody, all women, all girls who are going to be or planning to have sex, or I mean, nobody plans sex in that sense, but there is definitely some thinking. And all of this is under surface. All of this is under radar. So for India, again, I will close here and say that there is no truth, no one truth. There is no averages. Everything differs. We are not a homogeneous society. We are a very, very heterogeneous groups, and young people themselves are very different from one to the other. The access to contraception, access to technology, access to money, access to opportunities, and so on and so forth. So I'll stop here, and I will remind all of us again that within all of this, we need to remember FOGSI, because contraception below 18 will attract FOGSI provisions also. So I'll stop here.
Thank you, Dr. Kalpana. Thank you for your inputs. We move on to Dr. Sampath Kumari. Dr. Sampath, you're a champion as far as, definitely as far as adolescent health is concerned. Of course, you look into other subjects, but adolescent health and Dr. Sampath Kumari has almost become synonymous in FOGSI over the last 10 years. Girish and Supriya all are inspired by you, and so are all of us around you who know who you and how passionate you are about the subject. So you have done n number of school, college programs and rallies, and tried to create a lot of awareness among adolescents as far as nutrition and sexual and reproductive health is concerned. How do you think, how effective are these programs? Do you think it all matters and we should continue doing it? Do you think which one is the one which you grab the most eyeballs, where people really listen to you and people really come and ask questions? Which method works the best? So Dr. Sampath Kumari, here we're talking about tailoring contraception services for the youth. If you like to share your experience over the last couple of decades on what do you think ticks best in these school, college programs and the interaction which you have with the youth, and how much the discussion of contraceptive comes into the picture.
Thank you, Dr. Bazab and Dr. Shobha. Thank you for the wonderful opportunity. See, as you told, when we talk about the in school counseling, nutrition, menstrual hygiene, vaccination, and menstrual problems and the sexual health, once the counseling is over, I used to sit in the class for at least 15 minutes without writing the name. They will ask the questions. So without mentioning the name also, I will answer. The most of the questions will be concerned with this sexual act and the contraception. As already always I have said, even whether it is a rural or urban, one of the 8th standard girl is asking in the paper, how many times I can use easy pills in a month. So nowadays they are also aware. When we were house agency, that is in the 90s, that time when an unmarried girl comes to OP means she herself will be afraid to come. She has to get scolding from everyone, starting from junior to senior. Nowadays it is not like that. Now we are having for an house agency itself, respectful abortion care for 15 days posting. This is now going to come. Now it is practiced in my college, Muthukumaran Medical College and AIMS Delhi. In future, it will be for 15 days for the house agency. In my hospital, when I was asking to the house agents, they are telling, Madam, now they will not, it is not like that previously. The girl herself, she is coming and telling, I am sexually active with my boyfriend. We have to ask whether single or multiple. In this way, we have to ask the questions. Now the girls, as we know, as we are telling that we have, Madam was telling nowadays we are hesitant to talk. I don't, because for the past 10 years I'm doing the programs. No, so now I am very casual. If the adolescent girls are coming, are you sexually active? Are you using menstrual cup? whether the single partner or multiple partner, whether your parents know. But only one bad point is the parents are the last one to know that that girl is having that, because no girl will go and tell the parents that they are sexually active. So another one thing in our main common is the single room family nowadays. Most 2/3 of the population, they have the single room house only, everything in the house, cooking, everything. So the girls or the boys, sometimes they want to experiment. Nowadays, that is the age of the adolescents. They want to experiment everything. They do not know that the sexual act is a wrong act. As everyone touching, they will think that this is also a normal. So it is the duty of the parents, teachers, health workers, government, politicians, and with the help of celebrities to counsel the adults. So rather than getting news from the peer group friends, it is better to get the good information from the parents and the teachers. Parents should take time and talk to the children at least 10 minutes per day. Night dinner, all of them sit together and talk. This is the way I counsel. Then you can ask who is your friend, the friend, girlfriend or boyfriend. Like that, we can put a leading question. And if a girl or a boy asks the parent the question also, we should talk to them. We should encourage them. The anatomical parts should be explained to them. They should know what is happening. See, we are thinking only about the girls. Many boys, they do not know what is masturbation. They think that it is a disease. So we have to tell them that it is common and it is common for everyone. It is not a disease. So the counseling has to be continued. Yes, Basil.
Thank you, Dr. Sankalp. A wonderful hearing from you. Again, your passion towards the subject. We move over to Dr. Sangeeta. Dr. Sangeeta is another public health official who inspires us. We've seen her over the last decade in IPAS or IDF, as they call it, and the CAC conclaves, which is so meticulously arranged, is really worth everybody visiting, with the involvement of the judiciary and the legal system and the different ways in which MTP brings out different discussions and different dilemmas. So wonderful having you, Dr. Sangeeta, here. Today, our discussion is tailoring contraceptive services for the youth. And Dr. Kalpana has already set the ball rolling on talking about FOGSI. And obviously, when it's FOGSI, it always has to come to you. And if you can just share with us something with FOGSI, but more of the things about how IDF works in tailoring contraceptive services for the youth, how your few decades experience on the subject, we would love to hear from you, Dr. Sangeeta.
Yeah, thanks, Basab, for your nice words. Continuing to what Kalpana said, I think I will come to FOGSI a little later. I'll talk about the interventions or things that are being done for improving contraception in youth. I'll talk about those things first. And when I talk about youth, in my mind, I think youth is adolescence, of course. I think, but it extends up to about 24 years of age. So I think there are variances which come when we say the word youth, married and unmarried, and adolescent, and early youth, which is 15 to 19, and maybe then 20 to 24. So I think in our programs, we are addressing all these three categories differently, because all these three categories have to be dealt very, very differently. A little has already been said about, not little, but quite some things have been said about the adolescent and many mostly unmarried youth that we address. And so I will talk about that, but I will also talk about the youth which is from 20 to 24 and are zero parity or newly married also, because I think youth includes them also, and we need to address them also. For adolescent and early youth, the programs that IDF has undertaken, we've tried to address the issue from multiple angles, starting with the providers. Providers, when I say providers, I do not just mean the doctors. I mean the nursing staff, I mean the counselors, I mean the ASHAs, and even the peer educators who may not be the contraception provider, but they are knowledge providers. So I think a lot of attitude change and a non-judgmental behaviors have to get inculcated in all these cadres of providers. Because of course, not everyone comes to doctor first of all, but they do try to get information from counselors, from ASHAs in some way, but also peer educators. So I think providers is one big area that we work on. And as I said, different interventions, but for all these different cadres of providers, which are done differently. For some of them, we just work on busting their myths that exist. For higher level providers, we talk about some of the issues which are like giving them detailed information of how using all the contraceptive methods in youth is okay. It's there's no bias against using either an injectable or an IUCD in a nulliparous woman, for example. So there's a knowledge information giving for the higher level of providers, and more of myth busting for the lower level of providers. The second thing that we do is the community outreach, which is done through the existing system of public health, the frontline workers, as well as NGO sector peer educators. So I think they are also the ones, many of these peer educators are like in their youth, and these are the people whom the youth of our country approaches first. As you said, parents and teachers and doctors are the last to be approached. They approach their peers first, and they should need to know that what is contraception. The third thing that's done is we also get involved in school health programs for sexuality education. And there again, I think you really need to wrap it up really well. You don't need to tell them that, okay, we are here to talk about contraception or your sexual activities, etc. And just wrapping it really well, it gives them an opportunity for them to open up. And like Dr. Sampata Kumari was saying, that finally they come down to asking what their needs are. And I would say that I think let's start assuming that I think youth in their adolescence, etc., they do get engaged in sexual activity. So we should try to just address and tell them the information rather than trying to tell them that don't engage in sexual activity because it's an irresponsible behavior or something. Lastly, a few other things that we do is the community influencers. We also talk to PRIs and community influencers who also indirectly then influence the parents, the community around, because the one and foremost thing that if we address around contraception in youth, which is a non-judgmental, non-stigmatized approach, is the foremost thing that needs to come from all. So this is in brief about the interventions. I'll talk about POGSO. POGSO per se does not talk about family planning or contraception directly. But whenever there's a girl who is less than 18 years of age and talks about contraception, it immediately implies that she's sexually active and does get covered under POGSO. So in a way, POGSO has an indirect bad effect, I would say. It criminalizes the use of contraception. So as soon as we know that there's a girl who's less than 18 and is using contraception, our antennas just go high. And okay, so this is something that's happening under POGSO. So, but per se, the contraception and family planning per se, these services, etc., are not directly sort of covered by POGSO. This is in brief and in detail what I want to say.
Thank you, Dr. Sangeeta. Wonderful hearing you. We move on to Dr. Pragati. Dr. Pragati, thank you for your patience. Thank you for waiting so long. We have not had the pleasure of interacting much with you in FOGSI, but or possibly I haven't had it because as a vice president and before that as a chair of the family welfare, we did not have much of a scope of interacting with WHO and the ministry. So let's hear from you. You've heard the other experts here, Dr. Hema Divakar, Dr. Sampath Kumari, Dr. Kalpan, and Dr. Sangeeta. They have brought in various perspectives, both from the clinician point of view, clinician point of view, from the awareness, health awareness, creation point of view, and the public health point of view. We want to hear from your side, from WHO, from the ministry, how serious are they about these issues? I know there's a lot of manual set, there's a lot of resources in place, and there's a lot of logistic thoughts there, but how good it is works on the grassroots level and how good it is. And we want to hear from you, your experience on this topic. We're talking about tailoring contraceptive services for the youth.
Yeah, thank you, Dr. Basav. And although you don't remember, but I would like to tell you the instance. There was a consultative meeting with the Ministry of Health, and we invited you from Family Planning Division side.
Okay,
so at that time, I really got the chance to interact with you, but definitely a formal interaction was not there because at that time I was supporting Family Planning Division, Ministry of Health.
Thank you.
Now, regarding the question, so the question has many, I'll say, points, many collaterals, many pillars attached to it, and I'll try to address each one of them step by step. I'll keep it short because I understand that we are short on time also. So moving on to WHO side, at WHO India Country Office, we are operating under a framework of health systems pillar. So for those who don't understand about the health system framework, let me elaborate it. So health system framework talks about the 6 pillars for strengthening any services, any health related services. It talks about governance, it talks about service delivery, it talks about information technology, supplies, monitoring and reporting, and health workforce. And although it may sound very theoretical, but I'll give you the practical things that we are doing in WHO. Many of the aspects have already been covered by my previous speakers, but still I will touch base on it because there are some things that we are additionally doing on all those things. Starting from the governance, we at WHO, we are involved in policy advocacy with the Government of India, and under our Samarth initiative from WHO India Country Office, we conducted a systemic review on the conflation of laws. And as Dr. Sangeeta Batra talked about POCSO, there are certain conflation that exist in our laws, and that's true. And that is the, I'll say, a deterrent factor. And I can see Dr. Sangeeta smiling. That's a deterrent factor for all the service provider to provide services to adolescent. And when the name of POCSO comes, it's a kind of a ghost that comes in front of every provider that, yes, we are not providing any services to adolescent, but yes, we studied the conflation, and what we found out was that the definitions still vary in under different laws, and there are different aspects that we can reach out in the form of white papers or the advocacy form when we deal with the government policymakers. And FOGSI is one of a reputed say platform to talk about the policy changes. So under POCSO, as you all know, the problem is not per se family planning. The problem is of mandatory reporting. That's what we fear of, that we have to report each and every sexual interaction or the interaction of sexual things to the adolescent. It's not like that. We can definitely talk about healthy reproductive behaviors to our client. Nobody is stopping them. Healthy, say, we talked about menstrual hygiene, we can definitely talk about them. And that was the crux, that was the output that we came with when we studied this conflation of laws. Although there are many aspects when Government of India actually increased the rate of age of sexual consent from 16 to 18 years. So in a way, we are pushing our country back. Because earlier from 1940s to 2012, the age of sexual encounter was 16 years, but now it has been increased to 18 years. With a more media exposure, we are going back. Moving on to the service delivery part, WHO is increasingly working for this RKSK program. And we are into the training of adolescent health counselors. And in that particular training, we made sure that the sexual and reproductive health component is very well addressed. We get to listen many questions about the POCSO and how to reach the adolescents, and we try to address them. So more than 2,200 adolescent health counselors has been trained till now, and we didn't even stop during the COVID time. So COVID time, it was on and on through the virtual trainings. Apart from that, WHO is also involved in addressing the provider biases. So from the provider sides also, there are numerous biases, and we kind of make, some of us make of judgment about our client when they talk about, say, contraceptives. It is especially true for emergency contraceptive pills. So some of the providers may thought that the client is into the premarital sex or multiple sexual relationships. And let's face the fact that as a provider also, we are operating in a same universe. So whatever our community is thinking, our providers are also thinking the same. And we generally say during our trainings that try to work in your small universe, try to improve your concepts and your thinking in your small universe, and then talk about a bigger universe like a country or something like that. So that was the one of the takeaways from the adolescent health counselor training also. We are also into demand generation activities. So WHO is running many youth campaigns. So we had this recent youth campaign with over 20 million reach last year itself. And it was through the Radio Mirchi, the mass media campaign was done. And Dr. Hema Devakar talked about the boys. Definitely, boys need more sexual education as compared to girls, because there are many platforms for girls, but there are no platform for boys. So we created a mascot with the name of Hoshiar Kumar, certainly a male. And that's how we try to reach to this particular age group. And I would also like to talk about the information technology. So WHO is working on the gamma indicators, and like most of you might not be knowing about the gamma. Gamma is Global Action for Measurement of Adolescent Health. So there are certain set of health indicators for each country for adolescent health. And what we see is that many indicators are missing as far as this indicator framework is concerned. And we generally say, whatever you don't measure, you tend to miss it. So our aim is to, crystallize it more, to make it more robust, so that the countries find it easy to have that interventions in their particular program. We came up with a gamified version of a saver toolkit, and this we have done with the support of TNAI and ICOG FOGSI. So it's a safe abortion value, ethics and rights. It's a gamified version. This is specifically for the providers. So it's a game, interesting game that actually challenges them on their own thinking. There are questions that are related to their own thinking, own perception, and after that there is a kind of an education material that how you can be more unbiased and broad whenever you are dealing with this population. And let's face the fact, a man cannot fully tell the problems that a woman is facing. A woman cannot fully tell the problem what man is facing, and similarly the youth. What youth is facing, only youth can tell. So we are largely engaged with the youth organizations, and we are roping in them to basically strategize for our own programs. So this was in the nutshell about the WHO's role. And you also talked about Government of India. Yes, India has the largest adolescent health cohort. Let's face the fact, we are the youngest country in the world, and there is no escape from that. Government is serious about it. And Dr. Shobha Guri was involved in FP 2030 strategic document, which was a forward-looking document. And government identified this vulnerable group, adolescent group, as one of the key, client in as India will move forward to address the sexual and reproductive health. So yes, government is serious, but there are certain mismatch, and the only approach that will work is a whole universe approach. So we all have to contribute. Let's not talk about only policy, service delivery, government. It's a whole universe approach that will work out. That's all from my side. Thank you.
Thank you, Dr. Pragati. That's really a mouthful and a lot of new perspectives, a lot of things which we did not know before. And thank you for bringing all those things in. And that's really a lot to digest. And I hand over to Dr. Shobha, who will take the next round. And Dr. Hema has to leave for a talk. So we'll start with Dr. Hema, and then we'll take it from there. Dr. Shobha.
Sure. Basab, thank you so much for bringing in that vibrant element into the panel discussion. And you really made each person contribute from their organization the key messages. I just want to say one thing about FOGSO before we move on, and that is that probably we need to make our youth aware about FOGSO, because I think they do not know that indulging in sex before 18 years, completed years, either partner is a criminal offense in our country. They do not know. So that is the basic thing. I think, Sampath, so many things you told, this is also important, that they do not know that it is a criminal.
Can I just come in?
It is a moral outrage, but they don't think of it as a crime. So that is one thing. And the other thing is...
Shobha?
Yes, Sheila. Yeah. Yes, Sheila?
Yeah, I have put it in the chat.
We missed you during Dr. lecture. Yeah. I think the connectivity...
What we are facing is the girls, you know, the married couples are coming and the girl is below 18. And you know, we have to intimate the police. The police come and as a husband, the girl is alone. We had to literally request the police that not to arrest him till the girl is delivered. And there is nobody to take care. And I think it's becoming very seriously with us, because, you know, not look at restful care. And Dr. Hema is here and you are there. She really has to talk to Government of India. The 16 to 18, you know, if it's a consensual in Punjab and Tamil Nadu, Rajasthan, they have changed it. So we really have to do. Recently, we have now 2 girls who are in government shelter and the husbands are behind the bar, because they are from Assam and most of them are coming from Northeast. See, the social strata cannot be changed overnight. So this was police.
Yes, Sheila. Yeah. Yes, you got your message that married girls less than 18 are facing legal problems and their families because of lack of awareness about this. Got your point. And I think there has to be a social welfare officer attached to the law system who takes over, registers them and brings them for counseling, etc. But I think as far as the doctors have informed, there will not be any legal action against the medical fraternity and the hospitals, the facilities. Thank you for bringing that problem forward.
They have taken action against 2 doctors in Mysore district
because
they did not report.
They did not report.
And they were absconding for some time.
Yeah.
Okay.
That is what principally Pragati also said, that the problem in FOGSO more than the existing, the physical relationship is the reporting part of it. And that is what has created all, all hell has broken loose because of that. And we need to understand as practitioners what is our vulnerability in that. But I just wanted to tell that FOGSO as an act has to be informed to the youth, because I think we have a very, very smart next generation. And the moment they know that there is something like a FOGSO act, I'm sure they will put off their sexual debut to the next. I just want to bring in now the next part of the discussion, which will be the smaller part of the discussion, I promise the audience. And this is about, some of it has already been spoken. I think it is, my interest today is how can we engage or utilize or harness the digital and the social media in creating more talk about contraception. Because a few years back, menstrual hygiene, to talk about it was a taboo. Nobody used to speak about it openly, but today, many, many menstrual problems are solved because there is open discussion on it about the methods which are used, but that has not happened to the contraception. That and improving the contraception market in such a way that the methods become more affordable to the youth, because cost is always a challenge for them. So accessibility, affordability, the knowledge about it, and yes, the awareness and the demand generation, which some of the speakers have told, will it be promoted because of a very strong digital media presence of this subject? So we'll begin with Dr. Hema Divakar. Yeah.
Thank you, Shobha. Thank you, first of all, for putting all of us together. This was a very insightful and again, a stimulating discussion, urging us to do more than what we've already done before. So thank you ever so much. 2-3 points I wanted to place. One, taking the cue from what Sheila said about the pregnancy before the age of 18. Teenage pregnancy is a reality in the country. But given that opportunity, okay, she delivers for the first time, reporting, no reporting, keep it in a parallel compartment. Even the medical care professionals do not offer any contraceptive advice even at that point. So that's a huge gap, which is a missed opportunity. And I really loved what Pragati said about the gamification, etc. It has to be a youth for youth program, because if the peer group is what they're relying on, then we have to build the capacity of the ambassadors and leaders within the peer group to tell more about this, create leaders within the school who are the students themselves, who would be approachable. And also digital and technology. Yes, we can reach the last mile. Counseling in the regional language, very, very, very important, because even for capacity building and even for, giving any kind of advocacy advice, we have found that language barrier to be, quite significant. And the third thing is that confidentiality and anonymity. If the non-judgmental piece comes there, this is a boon, because there is a lot that can be deliberated on the digital platforms, and it is easy to approach, and there could be a forum where they could sort their myths and misconceptions. There could be a helpline to sort out their emergency queries, for example. So there's a lot, the digital and the technology base that you said. Indeed, there can be a lot that is happening. Having said that, clinicians, frontline healthcare providers should never, never, never miss any opportunity for anybody in this age group who are already sexually active or likely to be sexually active, whether they come for menstrual problems, whether they come for weight loss issues, the fancy scan report of PCOS, and everybody, at least they're frightened and approaching. That's a large mass there who is of a younger age group who is approaching with PCOS issues. We should never miss the opportunity to proactively raise these questions about sexual activity and offer them contraceptive advice. And again, lastly, within the FIGO group, the subcommittee members have engaged their registrars and the younger professionals within their own teams to create animations, TikTok-like videos, and infographics, and lots that can go on the social media, and creating the champions and trying to escalate and amplify whatever we are trying to say. And because it's a global voice, we have created some very beautiful things without a language barrier. You can just see that, you can understand what the message is, what it's trying to say. So out of the box thinking and working is the way forward, and the youth themselves will come out with very, very creative ideas. And so we should give the platform and the forum to them to help themselves, but we should be the catalyst to put the right information out there to take this movement forward. So with that, I think this is a brilliant discussion. Thank you for making me a part of it. Thank you.
Thank you so much, Hema. Thanks a lot. Thanks a lot. I think in the days to come, it will become more evident, how much of your thoughts have crystallized into action as you take forward your FIGO commitments. And we next come to Dr. Kalpana. Dr. Kalpana, the same question, whether the social media can be harnessed, and what are your thoughts? Give us some direction. Yeah.
Thank you, Dr. Shobha. I think we cannot move forward without accounting for or considering social media or media out there. Young people, or for that matter now, every Indian, most Indians rather, are very well versed with how to download content, how to look at links. Look how people are very happy to see TikTok videos, and the content consumption is very high. People really watch content a lot. Now, the thing is, challenge is not in having content. We all can create content. There is a lot of content which is required to be out there. And having said that, there is also all the content out there on the net, good content from good organizations, simple language with pictures or videos is also out there. The problem actually is that the connect between the person who has to use it and the content out there, which can be trustworthy, is the challenge. How does a person who needs to know how menstruation happens or which kind of contraception to be used and what are do's and don'ts reaches that? If you were to put a search word and look for content out there, you will find sites which have been paid for, the paid promotions really coming up, and the those sites which are not doing paid promotions are not going to be in the first frame of the mobile or the laptop, the top 5 or top 10. So I think now we, as people who are responsible to ensure, need to make this mental switch in our mind that when we think about the IEC programs or information education programs, when we do group meetings, we talk to people. Similarly, we need to now also start investing in 2 things. One is that we need to ensure that our content is simple and it is in a language that young people understand. And I don't even mean the spoken language like English, Hindi, Marathi, Gujarati, Tamil. That's also very important. But the language meaning the way young people communicate. The language, the slang, and I don't mean to say bad slang, but the expressions that they use, and make it simpler, make it fun, make it happy, so that the consumption by the young person,
make it more informal is what.
More informal, make it fun, use a lot of contemporary language or examples which are of, say, games, PUBG, everybody knows, or those kind of things, and not make it textbook heavy. We classically make our information capsules very technical and very bookish, which young people simply don't like it. If you see, and I will give you an example of 2 websites, two great websites in India, Love Matters. They have done an amazing job of information out there. And the other one is Agents of Ishq. If you see these 2 websites, they have small videos, small capsules of information, which are great. There are some other languages also there, but I think moving forward, we will need to invest in seeing that when we search for these keywords, our websites or the information that we put out there are in the top 5 or top 10, and we play around with the algorithms of these YouTube, Google, and others, so that young people can access. Otherwise, always, if you put information, even if you were to type, if there are no cache and no cookies already in your computer, you type, then you will go to suspicious websites, and then otherwise all foreign websites. So that is what I would like to say, that we need to also get our act together. And as FOGSI, as FPA India, as group of people who would like to see that it is information is there. I mean, it's not that it's not there, but it's not being used. So these 2 things I will say.
I think that is a very valid point you have made, that there is a lot of information there, but it is not used and it's not available to the couple or to that particular young person at the right time, at the right place. I understand what you say. Absolutely correct that we have a lot of information, but it is not of use if it doesn't reach that person in time. We go forward with to Dr. Sampath Kumari and what are her views, because her leadership in FOGSI is now something to reckon with, and she can make a difference to the practice of so many FOGSians. So Dr. Sampath, please.
Yes, thank you, Dr. Shobha. During the COVID period, the students, they were not going to school. Even the classes, everything was only in the online only. So similarly, the social media can be used. Now all from the even the preliminary school students also are well versed with using that. So we can create some, as Dr. Kalpana Madam told, we have the websites and we can put all the materials, what are all the contraceptions, where it is available, and what are all the contraceptions to be used, and similar talk, like that, talk, role play, dialogues, like that if you put means. Similarly, as Dr. Hema told, I used to do, whenever I go to a school, I select one school leader. That leader, I'll give my phone number. Whenever there is a problem for some girl, they will come to that girl and the leader will give a call to me. That leader will be there in the same school at least for 3 or 4 years. Similarly, the counseling has to be done and we have to put a lot of materials in the website and app. That Shobha is very well doing a lot of apps like that for adolescents. We can create an app and we can tell them where the contraceptive is available, because most of the time the adolescents, they are not able to talk to the parents. See, they are not voluntarily going to become pregnant. Suppose accidentally they are becoming pregnant also, they are very scared. to talk to the parents and they don't know whom to approach. They come with the friends to the doctors or wherever it is. They should go to the qualified place and they should get the correct treatment. So social media, with the social media, we can do a lot of work. In the recent era, that is the only social media, through social media, we can reach many lakhs of the adolescents. Yes, Shobha, this is my view.
Yeah, I think you are very right. The reach will be really very vast if we utilize, because and also each one of them has their own device and they practically live inside their phones and they connect more with that than with the family. So definitely it will have really, it will be very impactful if we can do something constructive there. Dr. Sangeeta, please.
Yeah, I think many things have already been said. I just want to add in that social media can be made more effective. And two things that will really go a long way is trying to put in a lot of factual, correct information, but also trying to address the myths and misconceptions. So if these two things like stand out on the popular social media platforms, I think this will go a long way. But also in addition to this, it needs to be backed by other digital interventions, which means that if they see something, if they know something, but they really want to just check with someone whether it's right or not right. So maybe having helplines and chatbots. Helplines is something that you can talk to someone, but also if you just want to type and ask your question. So social media backed by these digital interventions will go a long way in making it useful for our youth and adolescent to be better.
Absolutely agree with you, because when we tried to do something like this from the Family Welfare Committee and we had asked Tanu as a digital partner and we tried to direct youth towards that and it was working, it is still working. But what is absent there is the hand holding that you mentioned and the mentoring or the helpline kind of situation where we can engage and we can give our responses. So that connect was not possible. And I do see some challenges there, some challenge of provider-client, ethical relationship or some challenges are there which need to be worked out, wherein we can give medical advice in this way over a chatbot service, because nothing short of a teleconsultation has been approved by the NMC. So there has been some challenges in that direction. So we can give only general messages, but not real scientific medical advice. So there is that gap which remains, which we need to work around it. And maybe with God's grace and with persistent efforts of all of us, it is possible. Maybe FPAI will take the lead and, you will also join there, Sangeeta, and WHO also will throw some light on that. So we come to Pragati, and I think Pragati's work has been very dense in this. Let us hear what she has to say. Yeah.
Okay, so I think most of the things have been covered, but I'll start with a story, not story, but a real-time experience that we had. So we went to this very hard to reach area in one of our northern state, EAG state, I won't name the state, with the Government of India delegation and met these really enthusiastic young peer educators, because Government of India's RKSK program has these peer educators. And this young dynamic 14-year-old girl, she was quite unhesitant to talk to us, and she suddenly asked us a question. So the entire delegation was there and she asked a question, "Aap log vaginal patch kab leke aoge?" And we were quite surprised. The first question that we asked is, "Aapko kahan se pata chala? From where did you came to know about this thing?" She said, "YouTube pe sab kuch available hai. Hum to YouTube pe dekh lete hain." And then the question came to us was that, like, being a rural girl, she has a mobile phone of her own. So one of my colleagues asked, "But you're using a mobile phone of your father or your mother, and if they see that you are looking into this content, don't you, if you fear looking all these things?" She said, "Koi problem nahi hai, history se sab delete ho jata hai." Now, why I'm telling you this, that our youth is very empowered. Even the rural youth is very empowered. Telecommunication is increasing fast. So in 2020 itself, 50% of India's population was accessing social networks. And this is what the data tells to us, with a 4% growth rate each year for the social media. And I'll just give it a broad perspective. not only social media, but let's talk about digitization. So completely agree with Dr. Kalpana. What Dr. Kalpana has said, social media has, humongous information available, but we need to be more innovative so that the youth actually sees that particular thing. We do have chatbots. Ricket has his chatbot. Bonesha is there. There are numerous chatbots, but how to increase the access of these chatbots and how to increase the, how to maintain the interest of that youth. The retention rate has to be increased. Even the games do not have retention rate these days. So that's the biggest challenge. From WHO's perspective, we are also working on the self-care in a big way, and that also answers that how do we make sure that adolescent access to contraception. And we partnered with Ministry of Health to develop the self-care kits, and we are providing the digital barcode at each self-care kit, which will be installed in each health and wellness center, as well as the community, village panchayat bhavans. Simple barcode, it can be scanned and the information is there. So I'm not saying it's a very innovative thing, but definitely we have to look into totality. We have to see all the digital platforms, right from social media to digital barcodes, and why not virtual reality. So VR is coming in a big way. And we also talked about utilizing VR in certain matters where the counselor or the doctors are not comfortable to talk to. So talking about gender-based violence or maybe sexual education or sexuality. So truly agree that yes, social media has a big role. Social media is a future, and definitely a buzz is required for contraception marketing as far as social media is concerned. But we have to be more innovative, and we need to involve youth to be more innovative, because our mental capacity will be limited to our age only. Thank you so much.
I think you have hit the nail on the head by saying that contraception buzzword has to become more popular. So now is Dr. Basab available for the concluding remarks from his side? Dr. Basab Mukherjee? I don't see any message from him, because I have felt that today's platform was very valuable, very insightful. There were many key messages, and I just wanted to tell, I think, who was it who said that Dr. Hema came in and spoke about bringing in the boys in counseling. I think it was Pragati, right? Or Sangeeta. Yeah, so thank you. So when we were conducting school programs, we still do from time to time. And I still remember one instance when those were the beginnings when we spoke about these matters to the young people. And I was as amazed as Sampath when we took we used to take a basket around and ask them to put chits only with questions, so that, nobody comes to know the names. And of course, the chits had their own story to tell. And I agree completely with Sampath that today's clinical scenario is that there is a lot of practice of physical intimacy amongst our youth, and it neither has knowledge nor direction. And there is even seldom the relationships are also even not named. It is so casual in nature. So these things are there in our society, and we have a very large population to cater to. And today's discussion has shown us some insight into what all sectors are doing. So when it did happen that I started these sessions with FOGSI, and sometimes on my own, and sometimes through BSOG, my parent society, and I used to make sure that the boys play outside while we address the girls. And those were the days when we were not educating them together. It was only later I learned to take them together. And I went out after the session, and the boys asked me, "Namgenu helkodalva, madam neevu?" That means, will you not teach us anything? Why did you teach only the girls? And that is when I still have a picture with those boys with me. So that made me realize that we must begin with the boys as well. And I think that will make the youth empowered when there is irrespective of gender, everybody knows what is in stake, what happens when adequate knowledge is not there about contraception.
Shobha, you are muted.
Dr. Shobha, you have gone mute.
Sorry. I've just made some effort to put on slide what we actually discussed. So just a moment. The take-home messages from all. Please give me permission to share. And there is something wrong here. I'm sorry. Is my screen not visible? No. Yeah. I need to open the slide. Please give me a moment. Yeah, I got it. I got the PPT, and please give me a moment. And I didn't want this discussion to be, just go into thin air. So I made the trouble of putting everything. Can everybody see my slide? Can people see my slide?
Yes, we can see.
Yes, please.
Yeah. So in the first round, Dr. Hema acknowledged that the need is very high. She spoke about methods, which will create a block in the minds of girls. Ground realities, we must understand that there is a lot of need there. Dr. Kalpana rightly acknowledged that there is the largest cohort of young people, and their needs are different and their intentions are different, and we need to make it. We need to understand, and we need to factorize FOGSI into our programs. Dr. Sampath rightly acknowledged that there is a lot more need in the youth. I have spoken about all this again, and she also said that the need to educate is trans-sectorial and it lies on all members of the community. Dr. Sangeeta said that the provider group needs to be nurtured and encouraged, and community influencers need to be harnessed, and we need to be non-judgmental, non-stigmatized. Of course, Dr. Pragati laid out the entire WHO gamut of services. She spoke about the 6-pillar system, and that 13 conflations existed. And as far as FOGSI is concerned, a lot needs to be understood. She spoke about provider bias, demand generation, youth campaign, and GRAMA indicators, and the need to measure the problem. And I cannot agree more with you, Pragati, that we need to know where we stand. The second round, Dr. Hema spoke that digitizing is very important. We should not miss an opportunity, and try to use regional languages, etc. Dr. Kalpana said this is indeed the way forward. Content consumption is very high, but we need to streamline it. Dr. Sampath spoke about apps which they can access, and Dr. Sangeeta said that apps need not only be about the methods, but also about myths and misconceptions, and a chatbot service should support the initial information. I agree with you, Sangeeta, and Dr. Pragati, of course, said that today youth is far more empowered, and the retention rate for information needs to be increased. She spoke about self-care kit through barcode. She spoke about utilizing virtual reality. And I must say that this is the first time I'm coming across virtual reality in a clinical context, and we need to know more about it. And she also said that the buzz needs to be more. So let us talk more contraception is the final message that we wanted to. Dr. Parag is back with us. I hope, Parag, you got some of this brilliant discussion. I hope that is why I summed up the slides, especially for you.
Yeah. Thank you, Shobha. I was there throughout, except for last 10 minutes where I had to peep in the AMOX webinar. First of all, thank you very much, Shobha and Basha. It was a brilliant discussion. And of course, when you have panelists like Hema, Sampath, Sangeeta, Kalpana, and Pragati, I think we've picked and choose the best people in the field of OBGYN and public health. I've had an opportunity to interact with Sangeeta and Kalpana for a very, very long time, thanks to the Family Welfare Committee and Dr. Ritu Joshi, who was the chairperson then. So it's always a great learning experience, because as clinicians, we at times tend to forget the public health perspectives. And these are the people who really teach us and get us back to reality. And that makes us going ahead with doing good work. Brilliant discussion. And of course, the lecture by Nozer is always something which is a great learning experience. So thank you, Nozer, for joining us and giving us what we really need when we counsel our women who come to us seeking contraception. Thank you very much, all of you, for joining the ICOG program today.
Thank you, Parag, for coming in spite of your other commitments. And I thank all the panelists, dear friend Kalpana, Sampath, you are such a gem. Kalpana, you are most precious gem for my committee. My God, how much you supported my committee. I can never forget that. You were always
It's
there.
an honor and a privilege. Thank you for inviting me. I feel it a personal honor to be invited by FOGSI and you guys are doing such amazing work. And we are very close organizations, right? A lot of people on this call are also in FPAI. So
yes.
Nozer is, RP sir is there, starting from RP sir to Nozer, to you yourself. All of you are FPAI also. So yes, it's a honor. I'm very honored.
Thank you, Sangeeta. Thank you, Pragati. Thank you, Sampath. Nozer sir, your views on the subject today. Yes. That was a great talk, sir. That is, you're mute, sir. You're mute. Sir,
Sir, you are
muted.
So my only issue on FOGSI, and that's the tough one, it's the elephant in the room. We all have to start working together to create.
Thank you, Shobha. Parag, thank you.
Thank you, Sampath.
Thank you so much. Yeah.
Nozer's connection is
Ma'am and Prakriti.
Connection.
You.
Connection.
Thank you, Sampath ma'am. Bye-bye.
Thank you. Bye. Nozer sir?
I think he's frozen. His connection is not good.
Connection.
Yeah.
16 to 18, as all have, we know what we just text and we act and we.
Can I say a word?
Yes, sir.
Yes, sir.
What is mainly needed is to teach our boys, the male, to respect the female. Respect for the female folk down so much that they try to treat them as if they are inferior and as if they can do what they want and nobody can ask them a question. That sort of an attitude needs a drastic change. That both the sexes are equal, both the sexes are important, and both the sexes have to respect each other.
Absolutely.
Is presently needed very badly, especially for the boys who just treat the girls very shabbily. Thank you for giving this opportunity to talk. Thank you. It was an excellent opener. I wish more people are taking advantage of this good learning. They can get a couple of hours. I wish you all.
Thank you so much, sir.
Thank you, sir. On that note from legendary Dr. Soonawalla, I think we are ready to disperse, only to meet again under Dr. Parag's leadership, I think.
Still a lot of time.
Oh, yes, one more.
1.5 years.
Before that, we shall definitely do something.
Yes, yes. Thank you.
Everyone.
Bye, everybody.
Thank you all.
Bye. Thank you.
Sharing the points to all of you, and let us see what comes up. Thank you.
Bye-bye.
Bye.